Assalamu alaikum. Welcome after the vacations and after Eid holidays, and we resume from where we stopped. In the beginning, when we went on vacation, uh, we covered heart failure, and now we'll be starting off with the hypertension. And hypertension, this will be covered in two lectures. In first lecture, we'll be talking about its workup and how to diagnose, and in the second lecture we'll be uh, covering its treatment. Now today's presentation is made on Prezi, and it would be more say vibrant and more say active, and during the course of presentation uh, there would be questions, and you have to go through the whole of the presentation, note those questions, and answer those questions as part of your assignment and submit it by the evening. Now, what are the our learning objective from today's presentation? That after completion on this lecture or this activity, you should be able to diagnose and classify hypertension. You would know how to measure blood pressure accurately, how you should monitor the hypertension, and you will work up for the target organ damage and investigate the cause of secondary hypertension. Why we want to treat hypertension? The reason is that an increased blood pressure puts a load onto the vascular system and to the cardiovascular system, and this overloaded cardiovascular system, particularly the afterload increase because of peripheral vascular resistance, makes the heart to pump more forcefully, and as a result of that it would hypertrophy, and finally it would try to compensate, and but finally it would fail someday. It's a major public health concern. Almost 26% of the over adult population worldwide is affected by hypertension. There are figures, data from various studies that probably in around 2000 there were 972 million patients having hypertension, and in last 2 decades this number has gone almost double. There is suspected that as we said, there will be 60% increase by the year 2025. There will be 10% global health spending on diseases related to hypertension. And of course, it's quite a costly to treat and hypertension, not only hypertension, but all of its complications. So there are approximately 1.6 billion patients would be there in the world who would be requiring or needing a treatment. Now, in the European studies suggest that there were 81 million adults who have elevated blood pressure, and you break down this 81 million patient with the hypertension, only the number of patients who are diagnosed is around less than 78%. Those who are receiving treatment, it turns out to be around 68%, and who receive treatment but are still not controlled, almost 38% are despite medication not controlled. And then there is a major component of this hypertensive patient who have resistant hypertension, that despite treatment their blood pressure is not on target or on goal. So we have to keep all these components into consideration. The Pakistani scenario is not different. There is a health survey conducted on a national level by various organizations, and 18% of adult Pakistani population is suffering from hypertension, and 33% over the age of 45 are hypertensive. And as far as the adequacy of treatment or control is concerned, only approximately 13% or 12.5% patients are who are on control with medication. This is a very favorite slide of mine. It tells us that what happens to your cardiovascular risk or cardiovascular mortality with the increasing blood pressure. So if you see, you start from the left hand side of the graph, even at a normal blood pressure of 120 over 80, the mortality as a result of cardiovascular disease is 2 times more than the population who has a blood pressure number of less than 120/80, right? So increase in blood pressure, systolic blood pressure of 20 millimeter of mercury doubles that mortality, right? For each 20 millimeter of rise in systolic blood pressure, there is doubling of mortality. And think of it that someone who is having a blood pressure of 180 or 110 has 8 times more mortality as a result of cardiovascular complications or as a result of cardiovascular disease. So this is quite an alarming thing, that if just even say 20 millimeter rise increases the mortality. So generally, if you look at it, that we call that 140/90 is probably safe blood pressure to have in patient who are hypertensive, or your cutoff value of target for treatment. But even at this say number, the cardiovascular mortality is almost 2 times than that of those who are having blood pressure of 120 over 80. So our first question, there's a 35-year-old male who comes to your office for the first time for an annual medical checkup, and it was requested by his company. He has no other risk factors. His blood pressure is reading by proper method was 160 over 95, and after 5 minutes you check it, it was 150 over 55 or 92. You check it again, and it was 150 over 90. Apart from mild anxiety, his rest of physical examination was normal. So if you are a practicing physician, what would be your response? So we have mentioned in this case scenario that a single office reading is not enough to diagnose or label someone hypertensive. You have to do it properly with at least 3 readings with the 5 minutes apart, and then you probably take an average of that, and then record that average as his blood pressure, office clinic blood pressure. So with the blood pressure reading of around average of 150/90, what would you do? You would just reassure him that there is nothing to worry. You would label him that he is hypertensive and prescribe him antihypertensive medications. You would reassure him and prescribe just anxiolytics. You would reassure him, advise him some lifestyle modification, ask him to visit again after 4 weeks, or just reassurance and offer him ambulatory blood pressure monitoring or home blood pressure monitoring and advise lifestyle modification. So you go through this whole of this presentation and lecture, and then you have to answer this question accordingly. The answer is within this presentation. So how do you define blood pressure? Now, blood pressure is defined as a systolic blood pressure of more than 139 or a diastolic blood pressure of 89, either of it, right? So either a systolic is more than 140 or diastolic is more than 90, or both. This has to be based on the average of 2 or more properly measured seated blood pressure readings. The patient should be sitting comfortably in the chair or in the couch, and at least on each of the 2 or more office visits. Now this is the classification. There are various classifications by various associations. There is International Society of Hypertension, there is British Hypertension Society, there are so many, and then the, say, European Society of Cardiology. They all have more or less the same categorization. So your optimal blood pressure is, it has to be less than 120 systolic and less than 80 diastolic. When you have a blood pressure of up to 130 systolic and 85 diastolic, it is called as a high normal blood pressure, but some other authorities take it as 140 and 90 to be the possible upper limit for a high normal blood pressure. But anyone with a blood pressure of between 140 to 150 systolic, and 90 to 99 diastolic would be called as a grade 1 or mild hypertensive. Up to from 160 to 179 or 100 to 109 would be called as moderate or grade 2 hypertension, and then more than 180 systolic or more than 110 diastolic would be called as a grade 3 or a severe hypertension. Sometimes instead of grade they just choose stage 1, stage 2. Up to a blood pressure of 160 over 100 is called as stage 1 hypertension by the European Society, and anything above 160 called as a stage 2 hypertension, and then of course the third one we may call as a severe or complicated hypertension. As already mentioned, this international Society of Hypertension, they take it as up to 160 systolic and less than 90 diastolic as stage 1, and 160 and 90 above as a stage 2 hypertension, grade 2 or stage 2 hypertension. It is important that you record the blood pressure properly. The equipment should be regularly inspected and validated. There are three kinds of instruments available. You have the mercury one, the gold standard. You have the aranoid, or the one with this dial cuff, which right. And nowadays there are digital blood pressure recorder as well. Initially there was some reservation about using the digital, but nowadays it is recommended that digital is as good as say mercury blood pressure manometer recording, and the only thing is that it should be properly validated and rechecked again and again with a standard say BP recorder. The operator should be trained and regularly trained, that there should be no person to person variation, that the cutoff lines for auscultation should be very well defined, that when you call the Krotokoff sign to be absent and when you call it to be muffled. It's usually the muffling of the sound which is taken as the when you are using the auscultatory method, using your stethoscope, when the sounds, the Krotokoff sounds tends to change its character from or are nearly about to muffled. That is the pressure where you take the systolic blood pressure. When you are using the conventional method or conventional blood pressure like aranoid or digital, the mercury one, the auscultatory method should be preferred and should be used rather than just relying on the palpatory method. There are certain things which can elevate the blood pressure transiently, particularly the systolic blood pressure. So the caffeine, exercise, smoking, they can all have a bearing on the recording of blood pressure, and at least they should be avoided 30 minutes prior to the blood pressure measurement recording. Provide patient with say specific blood pressure numbers and the goal for the treatment, that you have to maintain your blood pressure in a given range. There, of course, it also matters that you use the properly sized blood pressure cuff. So the blood pressure cuff should at least 80% of the upper arm should be covered by it. Of course, it would vary from person to person, according to the arm circumference, maybe, and you may require a larger cuff for the obese people and maybe a smaller cuff for the pediatric age group. Usually what the way we record the blood pressure is that we say wrap the blood pressure cuff around the arm. We start palpating the radial pulse or the brachial pulse, whichever is easily palpable, and you inflate it to a pressure till the blood pressure, this disappears, right? And then you start deflating it, and then when the pulse reappears, it is the onset of the systolic blood pressure, and then you auscultate. Now, deflating the blood pressure cuff has to be gradual. You don't have to that you just pump it up to a high systolic pressure, and then you rapidly lower it down. The deflation should be at a rate of around 2 to 3 millimeters per second. Your patient should be sitting very comfortably. It should be with its back with the supported, not just in stand upright without any support. Legs should be uncrossed, and the upper arm where you record this blood pressure should be say it should not be done over the clothings. The patient should be made bare, and arm should be at the level of the heart. And you take at least two measurements, and then with maybe 2 to 3 minutes apart, and then take an average of that. Sometimes your systolic blood pressure may be inaccurately high. The patient may be in the lying position. Patient may have his legs crossed. It may be arm may be below the heart level, or arm may be unsupported, or you are using undersized cuff. All this can lead on to an erroneously high systolic blood pressure. This is again a representation of that how much the activity which is going on while you are recording blood pressure can affect, right? So while you are talking to your patient, it can erroneously raise a systolic blood pressure up to 17 millimeter and diastolic up to 13. If your patient is exposed to a cold environment, again it can have 11 millimeter of systolic and 8 millimeter diastolic blood pressure being raised. If he has just taken alcohol just before that recording, it can almost 8 millimeter for systolic diastolic. Supine does not have any effect on a systolic blood pressure, but your diastolic blood pressure may be recorded 2 to 5 millimeter less in a lying position. If your arm is above the heart level, it can lead on to 8 mm say difference in the blood pressure in systolic, right? So this means that say the cuff size, the arm position, the anxiety, and certain other ingestion of certain components can have erroneously high blood pressure recordings, and this should be always be borne in mind. So once you have examined a patient and it's his first encounter with you, and you found that the blood pressure is normal and he is not from a category which is there's a high cardiovascular disease risk in the family and does not have any other abnormality or CVD risk factors, all you do is that you recheck this patient in 2 years. But if you find him to be pre-hypertensive mean that above 120/80 but less than 140/90, so this patient then should be rechecked after a year. But if your patient is found to be stage 1 hypertension, which means 160 systolic and 90 diastolic or above that, that patient should have a reconfirmation within 2 months of this first visit, and then of course the strategy would be accordingly that he should be treated. But in stage 2 hypertension, you should not just be say not recognizing it. That should be within a month he should be referred for further evaluation, and someone with the blood pressure 180 or 110 should have an immediate evaluation, and within 1 week he should be say started on treatment. There are various risk factors for hypertension. The most common one would be advancing age, that with the advancing age you have developed arteriosclerosis, and the stiff vessels, they are difficult to distend as a result of when the systolic push of the heart pushes blood into the vessels, and of course there is isolated systolic hypertension, more common in advancing age. Men and postmenopausal women are more at risk of developing hypertension. Those who have family history of cardiovascular disease, they are at risk of developing that. Your lifestyle matters. If say sedentary lifestyle or more of a psychological or social stresses, they do also play a role. Smokers, say those who take high cholesterol diet, or those who do not consume fruit very regularly, they are at risk of obesity, of course, is a risk factor. And then the coexisting disorders like diabetes and lipid disorder, lipidemia. In fact, we may call this bring into metabolic syndrome as a whole as a risk factor. So someone with the central obesity or a waist ratio of weight, not waist ratio, but waist circumference of more than 36 inches in men should be considered as having, say, at least at risk of having metabolic syndrome, other component, and the insulin resistance. And of course, the alcohol intake also matters, that it will make you at risk of developing hypertension. Hypertension mostly is a silent disease, does not have any symptom. Many people do relate it that their slight elevation of their blood pressure may lead on to say headache or vague symptoms, but mostly there are no symptoms. The symptoms come on to as a result of the secondary effects of hypertension, which are the target organ which are damaged as a result of it. So I said majority of the patient would have no symptoms at all, and even they may not be aware of that they have hypertension, and they may be accidentally found to be hypertensive when some of the acute complication like myocardial infarction, stroke, or any peripheral vascular disease sets in. Some people do complain some symptoms like headache, morning headache, sometimes tinnitus, dizziness, confusion, fatigue, shortness of breath, changes in vision, or nausea, but they mostly would be related to the target organ damage affected as a result of hypertension or sustained or prolonged hypertension. Right? Now, so this is about how to say label someone hypertensive and how to diagnose them. Question number 2 is that you have a 70-year-old woman with the ischemic heart disease, known to have ischemic heart disease. She is already hypertensive, and she has a history of dyspnea or shortness of breath of grade 4 with orthopnea, with paroxysmal dyspnea, ankle edema, and confusion. She is non-compliant with her medications. Her pulse is 88. Blood pressure at that time is 200 over 120. Her respiratory rate is 40. Temperature is 98.6. There was no focal neurological deficit, and ECG shows signs of LVH. So, given the whole scenario, what would you call it? Is it hypertensive urgency? Would you call it as a refractory hypertension? Would you call it as grade 3 hypertension or resistant hypertension? Or would you call it a hypertensive emergency? These are the various terms which are used for these patients, and you have to come up after the next few slides that what should be the answer to this case scenario or question number 2. Right. The hypertensive urgency is labeled as someone who has severely elevated blood pressure in the upper range of stage 2 hypertension. And stage 2 hypertension was 160, 100 and above. But it is without any progressive end organ dysfunction. Like, for example, you have a highly elevated blood pressure without severe headache, shortness of breath, or chest pain. And usually due to this is under controlled hypertension. The emergency is that when you have a severely elevated blood pressure in the range of more than 180 systolic and 120 diastolic with progressive target organ dysfunction, right? So this requires an emergent lowering of blood pressure. For example, you have severely elevated blood pressure with patient is having hypertensive encephalopathy, altered state of consciousness, or fits. Patient is having this blood pressure reading along with evidence of left ventricular failure in the form of dyspnea or frank pulmonary edema, or patient has presented with an acute myocardial infarction along with this blood pressure reading, or is having an active angina at that moment, or there is risk of dissecting aneurysm, or you are found an inequality of peripheral pulses in your examination, and you might have noticed maybe early diastolic murmur in the precordium, and this may suggest that the patient may not have having a dissection of the aorta. And now these are emergencies. Here you can't just wait on that you have to reconfirm or reassure or whatever. You have to do some immediate measures. Now the question number 3 is that you have a 37-year-old overweight female who comes with a history of daytime sleepiness, snoring. She wakes up at night quite frequently. There is a history of edema of the legs or morning headaches, and she also have increased urinary frequency at night or nocturia. Her blood pressure is 159/79. It was rechecked and then you found it 160/79. Potassium was 4.1, creatinine was 0.87. So what does this suggest? Is this a primary hypertension? Would you call this a malignant hypertension, or a masked hypertension, or a white coat hypertension, or secondary hypertension? Now this then brings us to the types of hypertension, right? The primary hypertension, also known as essential hypertension, it accounts for almost 95% of the all cases of hypertension, and there is no universally established known cause for that. But still, there are say assumption that there is accelerated arteriosclerosis responsible for that. They may have some underlying renal abnormalities of a milder nature, and maybe majority of them may be suffering from a metabolic syndrome. We call it secondary hypertension, which is usually less than 5% of the patients who have rectifiable or correctable or treatable cause of hypertension, right? And it's there should be an utmost effort on part of physicians to recognize or identify these 5%, because treating this 5% cause may cure hypertension. In other cases, we are not talking of a cure from hypertension, we are talking of a control of hypertension. But in secondary hypertension, you may be curing the hypertension. Now, the cause of secondary hypertension, the common one include intrinsic renal disease, maybe kidney disease as a result of glomerulonephritis or interstitial nephritis. It can be renovascular disease like renal artery stenosis or renal artery fibromuscular dysplasia. Patient may have hyperaldosteronism or minerocholic excess, and sometimes sleep apnea syndrome has been linked with hypertension by various mechanisms. The uncommon causes of secondary hypertension may include endocrine causes like pheochromocytoma. It may be glucocorticoid excess or Cushing syndrome or Cushing disease. Some people with coarctation of aorta may have it, and of course both hypo and hyperthyroidism can be considered as a cause of secondary hypertension. When you suspect someone that he possibly has secondary hypertension, you pay special attention to their medical histories, right? And that sometime may be fruitful, that you can come up with, say, suspicion that this patient may have. So any hypertension which starts below the age of 30 years or after the age of 55 years can be related to maybe possible renovascular hypertension. Though fibromuscular dysplasia is more common in the younger age group, and atherosclerotic renal artery stenosis may be in the later age or maybe 55, 65 plus. Sometimes a sudden cholesterol embolus to a renal artery may lead on to an acute renal insufficiency, arterial insufficiency, and may be responsible for onset of new onset hypertension. Similarly, the severity, any grade 2 hypertension which is not responsive treatment should be suspected of possibly secondary hypertension. Then when you have hypertension which is episodic in nature, right? Sometimes it's there, sometimes it is not there, or maybe frequently there is headache, there is some chest pain or palpitation, right? So these symptoms of say episodic hypertension or very frequent headache or chest pain, palpitation, or maybe some thyroid dysfunction associated with it may be considered as possible secondary hypertension. And similarly, those with the history of morbid obesity and snoring and daytime sleepiness or increased somnolence should also be considered to be having secondary hypertension. On examination, presence of pallor or say anemia or edema or other signs of renal disease suggest a secondary hypertension. You auscultate for renal bruit and with a particularly a diastolic component, auscultation on the abdomen may suggest a possible renal artery stenosis. And again, the truncal obesity, stria, buffalo hump, or features of Cushing and say dryness of skin and say bradycardia, delayed reflexes may suggest hypothyroidism as a cause. Then some lab investigations may suggest that the patient may have secondary hypertension. So at the onset of hypertension or at the very beginning when someone is considered for hypertension, if there is an increased creatinine or there is abnormal urinalysis in the form of hematuria, microscopic or albuminuria, this does point towards a renal parenchymal disease and should be considered for a possible. It's difficult to say that this renal damage is before the onset of hypertension or it led after the this hypertension led on to this. But of course, any unexplained hypokalemia in absence of patient using any diuretics, particularly potassium-losing diurethiazide type of diuretics, should be reason to suspect hyperaldosteronism. High blood glucose level may suggest diabetes and may also suggest possible hypercortisolism or maybe say Cushing as a cause. If someone has impaired thyroid function test in while he is being worked up for possible hypertension, should also be considered for a possible secondary hypertension. So when you try to screen someone for a secondary hypertension, if you think that it can be chronic kidney disease is reason, you estimate GFR. If you think coarctation of aorta, you go for a CT angiography. If you think Cushing syndrome, you take a history and of course go for a dexamethasone suppression test. If you think of drug-induced hypertension, particularly those who has undergone say like renal transplant and are on cyclosporin, they can have hypertension induced because of that, or erythropoietin again is one reason. So for hypertension, so you look for. If you're suspecting pheochromocytoma, you go for 24 unimetanephrine and normetanephrine, and primary aldosteronism or mineralocorticoid excess test can be considered from 24 urinary aldosterone level. Renovascular hypertension like renal artery stenosis may be say screened through going for a Doppler ultrasonography of the renal blood vessels, or maybe more specifically by medical resonant angiography. Sleep apnea, of course, you would go for a sleep study or maybe oxygen saturation measured while patient is sleeping, and of course thyroid parathyroid through TSH and parathormone levels. Now, this is an example of say fibromuscular dysplasia in a patient with renal artery stenosis. Look at these corkscrew type appearance of the blood vessels on the here, right, in the renal artery, right, and this is was the before an intervention and after intervention. Look at this totally normal anatomy, and of course this patient had cured hypertension. This is another example. You notice this stenotic, this atherosclerotic narrowing of this blood vessels. Look at this before and after the treatment, and then how nicely this has restored the say blood supply to the kidney and has led on to cure of this hypertension. Now, our next question is, you have a 37-year-old female who comes to your clinic for consultation about contraception. Her blood pressure checked by you is 152/94. You recheck it and it's 148/92 after resting. Her rest of physical examination normal, and you're concerned about her blood pressure. that of course you would be concerned that if you are to prescribe oral contraceptive, which can maybe another additional factor to cause hypertension, should she be given or should she be not? Of course, it would increase the overall cardiovascular disease risk. So she was offered to have home blood pressure monitoring for 4 days, and after 4 days, average was 130/80. So what do you call it? This lady hypertensive, or she has pre-hypertension? Would you call this phenomenon to be white coat hypertension? Would you call it stage 1 hypertension? Or you call it masked hypertension? Or it's none of the above? One by one. The white coat hypertension is generally defined as an office blood pressure reading, difference in office blood pressure reading and out of office or home blood pressure recording. So you find an office reading always high and out of office, then this office means clinician office. So clinician office or clinic reading or hospital reading always high, but the home recording or out of clinician office recording is less. So this may be as a result of an alerting response causing acutely elevated blood pressure. So it may be as a result of this. Maybe 40% of the patients have say white coat phenomena, and there may be a blood pressure difference 20 to 10 millimeter reading variable reading higher in patients while they are recording in the office. The magnitude of this white coat phenomena depend on number of office readings. Say it also depends upon if it is taken by a physician or a nurse. It may be more prominent in elderly patients. It may be more in higher baseline pressure, and it also depends upon that which technique is being used for office or home recording, whether it is a right. So in these patients who always have this phenomena of more or higher reading in clinic setting and a normal or below normal reading in office setting, they should be offered ambulatory blood pressure monitoring or home blood pressure monitoring to exclude this. What is this ambulatory blood pressure monitoring is required for 2-3 reasons. You can probably rule out white coat hypertension. Ambulatory blood pressure values are usually lower than clinic readings. So these patients, these are awake individuals with hypertension with an average of 135/85 in awake conditions and less than 120/75 in during sleep should be labeled as normotensive. Normally, there is a what calls a nocturnal dip. So blood pressure drops by 10 to 20% during night. But if there is no nocturnal dip, that the reading in awake as well as in the waking situation is the same, it again increases the cardiovascular risk, and it's to be taken as a possible hypertension. By ambulatory blood pressure recording, you 24-hour average, if it is less than 135/85 in awake position, or daytime 140/90 and nighttime less than 125/75 should be called as normotensive, and anything above that would be called as hypertension and ambulatory blood pressure recording. While using ambulatory blood pressure recording, ensure that at least 2 measurements per hour. I mean recordings are made every 30 minutes. So there is some reservation about that as well. Because when you are a cuff inflated onto your arm and in every 30 minutes it is inflating and deflating, it again arouses sort of an anxiety in patient, and sometimes this may not also be as effective a tool to rule out the say white coat phenomena. Right, so the at least average value of at least 14 measurements should be taken during person's usual waking hours to confirm the diagnosis of hypertension. This is the kind of graph you get in patients with the ambulatory recording. That is the upper blue is the systolic blood pressure, and then you can note down that definitely there is a dip in blood pressure at around 4 a.m. or a late night dip, which should be there. Sometime it is not feasible to go for this 24-hour blood pressure recording for a prolonged period, or a patient do not say like it. So in that case, you can probably rely on multiple blood pressure readings recorded at home. And again, it's also important not only for the diagnosis point of view, but for management point of view, that after treatment, do they have the desired response to treatment as well or not. And of course, that would improve their adherence to the therapy as well. Right. So when you use home blood pressure recording, again, two consecutive measures to be taken at least 1 minute apart. At least 4 days continuous reading should be taken, but preferably for 7 days. And day 1 and day say reading should be probably excluded from the say calculations, right? Again, there is quite a bit of say variation as is depicted in this chart, that the office reading on an average was 148, self 138, and ambulatory blood pressure reading 113. So almost 10 to 15 millimeter of systolic blood pressure differences on an average in a patient when they are recorded at home. The masked hypertension is that you have the opposite of white coat phenomena, that the office reading is usually normal or less than 140/90, but the clinic reading usually is say out of the clinic reading or home reading is usually high. So it can be say seen in 10% of the population, and it still increase the cardiac risk and target organ damage. Resistant hypertension is that when blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive agents of different classes, right? So this is would be called as a resistant hypertension. Now, our next question is that you have a 25-year-old female primigravida, and her last menstrual period is 7 months back, and she comes to your office for a routine antenatal care. She's coming forth complaining of frothing in the urine and some mild headache. Blood pressure is 150/92. So she's 7 months pregnant, 25 primigravida, with the blood pressure reading of 150/92. She was not previously hypertensive, and 24 urinary proteins are ordered, and this less than 0.5 gram per day, and the blood pressure reading is 148/90. So what do you call it? Is it chronic hypertension? Is it preeclampsia? Eclampsia? Could it be HELP syndrome, or we called as in pregnancy induced hypertension? So you have to go through this scenario and then go through the remaining slides and then come up with what this could be. Pregnancy-induced hypertension can have 4 categories, like chronic hypertension, pregnancy-induced hypertension, preeclampsia. Preeclampsia is super important chronic hypertension, and it's the third leading cause of maternal mortality. And maternal diastolic pressure of more than 110 over diastolic blood pressure more than 110 is associated with almost increases of abruptio placentae, fetal growth restriction, and so many other complications. The risk factors which can lead on to this say pregnancy-induced hypertension is the first pregnancy, younger individuals less than 35 or less than 18 or more than 35, they are likely to be a prior history of preeclampsia, black race, medical risk factors for preeclampsia like chronic hypertension, renal disease, diabetes, antiphospholipid syndrome, twin pregnancy, family history. They are all risk factors for developing hypertension during pregnancy. Pregnancy-induced hypertension is called when you develop hypertension for the first time during pregnancy with the blood pressure reading of 140/90 above, and usually mid and late in pregnancy. There are no renal or other systemic involvements, and usually resolves 12 weeks postpartum. Preeclampsia, of course, with the onset of proteinuria of more than 300 milligram per 24 hour along with hypertension. Right. Then again, of course, we just leave it for some other time. That how do you differentiate? We leave this at. Right. So this is you've got the blood pressure of a teenager who lives on a junk food, TV, and a computer. Okay. A 65-year-old diabetic female comes with history of angina, uh, Canadian class 2. Her blood pressure is 155/88, pulse is 86. She was taking insulin and her A1C was 6.5. No previous history of hypertension. She is now experienced vision problems and also complaining of frothing in the urine. So you start her on anti-anginals, antihypertensive drugs, statin, lifestyle modification, all is done. What would you do? You would start her on anti-anginals, antihypertensive, statin, lifestyle modification. You would refer her to specialist care for a cardiologist and nephrologist. You will order an assay of ECG, urine, lipid, stress testing, or echo, or you would do all of the above. Okay. When you have someone diagnosed to be hypertensive, whether for the first time or is hypertensive known and comes to the clinic, what are the minimal lab tests to be done? You should do an ECG, you should do a urinalysis, you should do a blood glucose and hematocrit, serum potassium, creatinine, you should estimate a GFR, calcium level, get a lipid profile after 12-hour fast, and which should include HDL as well as say LDL cholesterol, and you can also measure the urinary albumin excretion or albumin creatinine ratio, which is say marker for cardiovascular disease, and then you might have to go for a more extensive testing for identifiable causes, which is not generally indicated unless blood pressure control is not achieved. You have a 55-year-old overweight male who comes with a history of smoking 20 packs per year. It's his second visit. Blood pressure is 130/43/91. You recheck, it is 140/90. He had similar reading previously, and you have advised him to quit smoking, um, change lifestyle, dash diet plan. Not best course of action. Now, after you have already tried all this, would be that you check for his adherence lifestyle modification. You advise him ambulatory or home blood pressure recording. You label him stage 1 hypertension and prescribe antihypertensives, or you just reassure the patient, ask him to visit 3 months later. Or apart from antihypertensive medication and lifestyle modification, you also look for target organ damage. So what strategy or what line of course of action will you take on? When you look for the target organ damage, the complication of prolonged hypertension can lead on to changes in blood vessel, leading on to arteriosclerosis throughout the vasculature. This is primary reason for say target damage into the heart and CNS and kidneys and peripheral nerves. The target organs affected are CVS, heart and blood vessels, kidneys, nervous system, and the eyes. The effect on CVS would be left ventricular hypertrophy, which can be seen through ECG or echo. It can lead on to arrhythmias. It can be lead on to coronary artery disease or acute myocardial infarction, arterial aneurysm, dissection, rupture, and not to forget as already mentioned, arrhythmias, particularly the atrial fibrillation is likely. Now, this is the kind of say response you get on echocardiogram. Look at this markedly hypertrophied left ventricular cavity, which just obliterates during systole to an extent that there is no lumen left. So this is ECG showing marked left ventricular hypertrophy. The patient with hypertension can have stroke, intracerebral or subarachnoid hemorrhage, and cerebral atrophy and dementia. All can happen. You may have say marked this intracerebral bleed. Kidney can lead on to the hypertension can lead on to glomerulosclerosis, leading on to impaired kidney function, maybe proteinuria, and of course ischemic kidney can further lead on to say further worsening of hypertension through increased renin being released. This is the kind of histopathological changes you get in as a result of hypertension in kidneys. The eyes, of course, all this starting from normal retina, look on the left side, and the right side you may have hemorrhages, exudates, cotton wool spots, and some micro, maybe called as microstrokes. Now, in summary, for patient and workup of hypertension, take proper history of symptoms, family history, and check for signs. Take proper blood pressure measurements, and then monitor, say, their ambulatory blood pressure recording or home blood pressure recording if required. Classify hypertension. Look for secondary cause of suspected patients. Get lab tests like creatinine, lipids, electrolytes, urine complete, ECG. Look for target organ damage. Refer the complicated difficult patient for specialty care. Thank you.